Okay, so it is October 25th, and I'm doing a live here for those that are a little familiar or not familiar at all. Usually I jump onto these for about 20 minutes at a time. Usually when I've just taken a nap, so I have to run very abruptly. It is usually because one's coming downstairs or one's waking up. So let's just get right to it. Usually I'll do some question and answers, but the things I'm going to talk about today is spinal stenosis. So let's start with a definition. So what is spinal stenosis? Essentially, if this is the spine and this is our spine model, if you are looking down the tunnel of the spine, this is the bone or the vertebral body. So whether it's in the neck or the lumbar spine, the vertebral body here can get squeezed or pinched. And there's usually think of it this way, three ways you get spinal stenosis. You can get it from the joints in the back having significant arthritis, these joints rubbing up and down. When they get significant arthritis, they start squeezing the nerves in the back. That's one way. You can get it from something called spondylolisthesis. That's when there's either so much joints, 6 types, but in general, it's when the joints have so much arthritis, they can slip forward. That's a major cause of spinal stenosis, is spondylolisthesis. Or you can get a disc herniation. So if this is the spine, again, disc pops up, pushes through. That's another form of something that could cause spinal stenosis. Again, spinal stenosis is just a big fancy word for the nerves getting pinched in the back. And that's what I want to go over today is what is spinal stenosis? What are some of the major causes of it? And then importantly, what do we do about it? I'm going to focus more on the surgical options, being a surgeon. I'd say at least 90 to 95% of the patients I see in a given day, given week, given month, we don't do surgery on. So while I have a lot of non-surgical options, I'm going to focus this conversation to kind of what you've done once you failed all the surgical stuff. Failed all the non-surgical stuff, and we'll talk about the surgical stuff. So with that being said, I'll try to get to a couple of questions here when they come in. I see a lot coming through. We'll go forward with it. But again, spinal stenosis, big fancy term. Essentially, it's when there's compression of all the nerves centrally down this canal. Now, the other thing that stands out is a word called foraminal stenosis. And I think of it as like a tree trunk and the tree branches. The tree trunk is the cord or the thecal sac. That's central. That's where spinal stenosis is. And the tree branches get pinched. That's foraminal stenosis. Foraminal stenosis. So that's the two different types of stenosis. In a way, you can get foramen, pinch of the nerve tunnels, and spinal stenosis in the center. So one of the things that has got me extraordinarily good results trying to think about a humble way to say it. Maybe that is, maybe that's not, is just doing something called a minimally invasive ultrasonic laminectomy for spinal stenosis. And for everyone at home, they're like, I don't know what any of those words mean. Like, what are you talking about? So if this is the spine, you lay down, you go to sleep, you're intubated, great. And we roll you over. Use this spine model right here. Again, okay, so you walk in the OR, you get intubated, you go to sleep. We roll you over to another bed, you're laying down. So on the back part of the spine, this is usually at L4, L5, sometimes L3, L4, sometimes L5, S1. I can use a small incision. I say it's about the small size of a credit card, depending on how many levels. Over this part of the back, I tease the muscles aside, both on the left and the right side, or might be just on one side, depending on the levels I'm doing. And then I use this tool. Actually, I have the tool now here. I have pieces of the tool. The whole piece, I think, is really expensive, and I'm not going to go buy the tool just for this. But this is one of the disposables, and here's one of them, what they look like. This is from Bioventus, a couple different brands on it, and I can make a cut into the bone. This is what the ultrasonic technology looks like, just right here. Almost looks like something in the dental industry. The one I actually use is a little different than this one. It's a blade. It actually looks like a knife, and if you rub it on your finger hard enough, you could cut something. It's almost like a plastic knife. Like you could cut something with a plastic knife, but you'd have to really get a good angle and really work on it. But pretty much I use this tool. It's irrigated, and there's another power cord that comes off. Again, I don't have the whole setup here at my house. That'd be a little ridiculous. I can shave off, melt down the bone, and it really is melting bone. I have a bunch of older videos on it. I haven't taken one on it in a while. I probably should this upcoming week. I melt down the bone, and now I'm in the canal. Now I can take off the thickened ligamentum flavum tissue. I'm wearing these glasses that have loops. They're called loops. They're about this big, almost like magnifying glasses on it. They are almost like they are. They're 4.5 times zoom, panorama view. They're very fancy and cool. kind of clean out the nerve tunnels. Then I can use this tool here to kind of get into the nerve tunnels, scrape the superior or inferior articular process, big fancy words for the facets, and open it up. In general, again, everyone's a little different. And I kind of use, I don't know much about cars, honestly, but I use cars as an analogy here. Everyone, if every human's a car, there's different models or different years, there's different conditions of cars. So when you bring your car to the shop, not all recovery is the same. It's based on kind of how your car was in going to that shop, right? So with that saying, if you're some 60-year-old or 45-year-old even, but 60-year-old patient, you get a 1 level or a 2-level laminectomy. Usually the results are this. I let you go home that day, depending on the number of levels, usually 1, 2, maybe 3 levels. I'll let you go home that day. The incision's about this big on the back, not terribly small. I'm not saying, oh my God, I have the smallest incision in the world, but I don't want to miss anything. I'm trying to find something that like a dollar bill or something, or a writing utensil, because it's hard to say like what that is from home, right? So here's a writing utensil. So, about that big, that much of a writing utensil, that small part of it on the back, clean out that area there, open the nerve tunnels. And the goal of the surgery is to help two things. A term called neurogenic claudication, which is like heaviness in the legs, shooting down pain in the legs, something where you're like, okay, when you sit down, but when you first start walking, your legs are just heavy. You have to get a shopping cart. It's a classic shopping cart sign, is almost synonymous with neurogenic claudication. That's what we're fixing. Also, radiculopathy or sciatica or pinched nerve pain, numbness and tingling running down the legs. Depending on the nerve, it goes to different levels. Usually L4 is kind of front of the thigh, then side of the thigh, down the knee. L5 is side of the thigh, down the side of the leg, on top of the foot. S1 is back, or is in the butt, down the back of the thigh, kind of under the back of the calf, under the foot. And then cervical spine is kind of the same thing. I'm not going to go through it, but usually like this pattern right here is a C6. Going down here is a C7. Here is a C8. Either way, a little different talk. But that's what the surgery for spinal stenosis is fixing. That's what the laminectomy is fixing. And that's in the lumbar spine specifically. And so I tell people all the time, look, the goal of the surgery isn't necessarily to fix back pain, because that could be from many different things. It's to fix nerve pain. It's to fix leg heaviness. It's to fix weakness in the legs. It's to fix numbness and tingling. Does back pain get better from laminectomies? Kind of. That's not the goal, but like it definitely does if certain other factors are met. So it's kind of a confusing thing. Look, if you're bone on bone, if you got scoliosis, doing a laminectomy is not going to fix all your back pain. But if it's from severe spinal stenosis, compression of the nerves, yes, it will. And there's good studies to show that. But that's kind of why we just set expectations. And, I can even see I can't confirm or deny if anyone's a patient on here from weird HIPAA laws, but I have a lot of patients in here, and, it's flattering to see them vouching for me. Actually, I was just going through this today. It's in here. Like, I decided to start keeping them. Not that I throw them away, but just many, many nice thank you notes for so many patients just over the years, just thanking me for doing these surgeries. And that's why I personally like doing laminectomies. Look, do I do fusions? Do I do disc replacements? Yeah, all the time. I might do more fusions and disc replacements than laminectomies, but a laminectomy is most spine surgeons' favorite surgery to do because of the results. It's easy in the scheme of things for spine surgery. It's efficient. Patients get better fast, and there's very low complication rates. Intraoperatively, very few things can pop up. Postoperatively, very few things can pop up. You're not relying on a fusion. You're not relying on the bone healing. You don't have to worry about screws loosening. Infection rates are much lower. Narcotic need and associated things with that are much lower. So there's just a really good role for laminectomies and spine surgery, taking the pressure off the nerves. All right, so I see a lot of great questions here. And just as a reminder, just kind of reset with everyone, kind of just jumping on. I'm just going to rapid fire some of these questions, and apologize if you've been asking and haven't got to it. So I'm a spine surgeon here in Dallas, Texas, born and raised here, grew up here, and then left for about 10 years to do training. People are wondering my Canes hat. Well, my Mustangs lost today. I don't want to talk about it. They are stinking pathetic losers. I still root for them, and I'll root for them next weekend when they play Miami. But I lived in Miami for 5 years, going to University of Miami, but I'm mad at them. I don't have a great scrub cap for them. I got a good scrub cap for Miami, so that's why I'm wearing Miami. But my allegiance is still to Miami. Unless they win next weekend, then maybe I'll just Sorry. My allegiance is still with SMU. Sorry, I'm reading these questions. My God, I can't go on the record saying that. All right, let's get to some of these questions here. Enough about me. So, question from American Patriot. That's a good name. Would be an obstacle for going a disc replacement C4, 5, 6, 7 instead of fusion? Did I miss another part of your question? What would be an obstacle? I guess an obstacle would be the skip level. I don't hate. I don't love. I don't hate. It's great when they're both together. So I'm kind of wondering why you think it's those two levels, because that's a pretty narrowed in diagnosis. But in terms of those two levels, fine. What would be an obstacle? If you have severe disc collapse, if you have severe neck pain, that might steer me away. If you have giant bone osteophytes, that might steer me away. Are there open MRI machines from Classic? Yep. Open MRI machines are okay. It's almost like watching a football game on a TV from 2005. Can you see it all? Can you get the idea? Yeah, but if you got a closed MRI is better. From another one, how long do you go dealing with pain before surgery? There's not a set timeline. I would think of it, the term is activities of daily living. I have a lot of videos on YouTube on this, like when to do surgery, when to not. Pretty much when you can't hang out with your friends, can't hang out with your kids, when you can't wrestle with your kids, you can't, throw the ball. I have kids, so that's a big part of my activities of daily living. Throw the basketball, throw the lacrosse ball, kick the soccer ball. Okay, now you're older. You can't pick up your grandkids because it's just shooting down. You can't walk around the block. You can't walk your dog. Those would be the indications for surgery. Good question here from JZL3000. Do I also do laminotomy? Is that preferred over a laminectomy? I would just think of it as a laminectomy as the full thing, whereas a laminotomy is one thing. If you're seeing this, you're in the social media world, right? There's other spine surgeons in the social media world also doing kind of the same thing I'm doing in terms of talking to patients. I don't know if I call it a pet peeve, but I think the biggest problem is doctors out there saying that laminectomies are bad, which blows my mind. And they say it creates instability. So, fly down to this southern state that's not Texas and cash pay for this fancy procedure. Look, laminectomies are great. You can do multi-level laminectomies and they don't create instability. The people that say that, send me the publication that says that. Look, if you take too much of the pars, yeah, for sure, that's an iatrogenic spondylolisthesis, but that's not what we're talking about. So I see too many people that live in pain or go pay like $60,000 for some fancy spine surgery that they don't necessarily need to pay that much for because they're so afraid of a laminectomy. But kind of going there, if you need a laminectomy versus a laminotomy, I would think of it as laminotomy as unilateral, one side, laminectomy is both sides. Laminectomy is a more powerful surgery. I would do a laminectomy on, not my children. I'm not going to operate on my children, but my best friend or something like that all day. It's so much better depending on what you need. If you only need one side, a laminotomy is good, but I wouldn't be afraid of a laminectomy because of a YouTube video that someone put up in the Carolinas area about laminectomies. I'll just leave it at that. Okay, so let me get to a couple questions here. Can big people get a disc replacement from Rocco? They can, but it's a little tougher because you need to have perfect visualization of the neck for disc replacements. And on a fusion, for instance, you're like, well, you don't need perfect visualization. Well, you see it. I mean, you're looking there, but the x-rays, the fusion can tolerate a lot more. You can get in not the absolute perfect size, whereas the disc replacement with the absolute perfect size, like to the millimeter, whereas that's not as critical in a fusion necessarily is one way to think about it. Or sometimes in the disc replacement, you can't see the back wall. So long story short, big people can get disc replacements. It's just a little tougher. And the initial indications were no, because you couldn't see everything perfectly. 2-level disc replacements. Yep. Actually, check this out. You guys want to see something cool? I just got a new phone. So now I have 2 phones. Now I can actually show images on my phone, which I've never been able to do, although I'm sending this phone back to Apple because they're buying it back from me. But for a week or 2, I'll have 2 phones, which is kind of nice. But here's a pretty cool image right here. I can't. So right here is a 3-level disc replacement. How about that? That's one. Hold on. That's one I did. I can't tell you when I did it actually from like a HIPAA standpoint. Man, that shows up really well on the screens. But that's a 3-level neck disc replacement I did just this week at, well, not this week. I did it sometime this month or sometime in the last couple months. I'm trying to think when I did it actually. I'm not totally sure. But it was at 3 levels. And, in terms of doing multi-level disc replacement, it's something that's tough to get done with the insurance companies because legitimately they're evil. People that work for them I'm jokingly saying are evil and they're terrible and we should be protesting against them. So they really hamper care. They really hurt patients. And I'm happy to go on the record saying a lot of that because I think just nothing good about the doctors that go work for insurance companies, the peer-to-peers, the people that do approvals, and more so the people that do denial. So obviously I'm jaded, I'm biased. I think the insurance companies are terrible. I don't know how it's going to change, but that's not really totally what we're talking about. So look, let's go talk more too about spinal stenosis because that's trying to be the theme I'm going for today. I've been trying to focus on that necessarily. And I do see some people sending gifts. Don't send any gifts. Save those for other creators trying to make a living on social media. I'm just doing this to help people. I kind of jokingly say I'm a spine surgeon. Look, I'm doing fine. Save your time and money for people live streaming from Africa or something like that. So, okay, great question here. My son is a second-year resident orthopedic surgery at Rush, currently at AUKUS. Yep, they're here in Dallas right now. AUKUS is a big joint replacement meeting. It's here in Dallas every year. I think it's kind of cool. It's always in the same city every year. A lot of them change cities every year, but I got a bunch of buddies who are joint replacement doctors, and here in Dallas, I went to that. I've actually gone to the meeting twice. Like I didn't register for it, but I drove, not like 20 minutes away and hung out with my buddies during the day, and they kind of just skipped the meeting. We just hung out at the hotel pool, hotel bar, and it was fun. So it's a fun meeting. Okay, seriously, we got to focus. We got to focus on spinal stenosis. So let's talk about again a couple of the recovery for spinal stenosis. So if you do a laminectomy, I guess it's me that does it. It's the incision about this big on the back. Open the muscles. I let you go home that day. Look, if you're from out of town, out of state, I'll keep you overnight. I kind of tell patients I care about you, but I don't care how long you stay. If you want to stay 2 nights, 1 night, it's fine. So you stay overnight, go home the next day, go home that day, or stay in a hotel for a couple of days. A little different argument in terms of that process. But I want you up and walking that day. I want you urinating that day, passing gas that day, walking around to physical therapy that day. That's a big deal in the recovery. For the first 6 weeks after a laminectomy, especially when I'm doing it with the ultrasonic technology, I don't want you to lift more than 15 pounds for the first 6 weeks. I have a Velcro back brace that I give you. Unless you have United Healthcare, they don't pay for Velcro back braces. Even though you've paid God knows how money, they don't provide that. So I send you to a website and you have to get your own. Again, just another reason I hate the insurance companies because how stupid is that, right? They're like, we're not going to buy this back brace for you, whatever. Either way, I have you in a Velcro back brace for the first 6 weeks. After 6 weeks is when we kick into high gear. After 6 weeks, I discontinue essentially all restrictions. Now, again, does this vary per patient? Yeah. I have some patients who are knuckleheads who do motocross, and I'm like, well, don't go back to that yet. Could you? Yeah, but chill out. That's kind of what I tell them. And but for the first 6 weeks, nothing more than 15 pounds. After 6 weeks, I take off all restrictions. I let you get back into the pool, hot tub, swimming, and I highly encourage aquatic therapy. I think that's a really big deal in terms of recovery. We start formal physical therapy 2 times a week for 6 weeks. And this is after a laminectomy, especially when I use this ultrasonic technology. And that's a big deal, is using the ultrasound to fix, to cure, quote unquote, at that level, the spinal stenosis. Again, appreciate the likes and shares coming in. That helps promote this to your peers who are going through the same thing. And I see a lot of my patients, either former or ones coming up on here, talking great things about me. And, I don't know how you guys do it, but maybe connect with each other. I think it's a great way to validate the services we do here and kind of find good care. So a good question from RP Price. My first surgery is L45 decompression using a bilateral laminotomy. My neurosurgeon and I decided that the structural integrity of my spine would be structurally compromised. Okay. Well, good. I'm glad. So if you did good, you did good. I appreciate that comment. Guess there's no question mark there. Next question, Junebug Dragon. How long does it take for pain to go away after a fusion? Well, let's kind of go down that, and I'm going to kind of shifting it back to a spinal stenosis. So like if you get a fusion for spinal stenosis, let's talk about what that means. Here's a really, sorry, it's raining like crazy outside. Here's a really nice spine model I have. This is, it kind of looks like this, right? If this is a spine, bone, disc, bone, this is one where it has a spacer in here, and it's got screws. And for those that follow me a lot, they know exactly where I'm going with this. But this is what minimally invasive surgery is, especially minimally invasive fusion, where if you're looking at this being like, what the actual heck is that? I don't want these. No. This is how I put them in. And then the technology I specifically use, I don't have all the tools with me here, but I break this off right at that mark point right there. I break this off, and then that is what's left under with a minimally invasive fusion for spinal stenosis. So like here's some other pedicle screws here. So they go in, and then the tower breaks off, and then you're left with just this. So it's not this huge tower. Now at home, you might be like, well, why do you even have that tower? What is the point of that? Good question, Sam. Here's the point of it. So if here's your spine, big model here, and you have all this tissue, especially if you're big and fat, which I hope you're not. Better for me, better for you if you're not. So you have all this tissue here. I don't need to go expose all that tissue, pull all the skin off, go look at every single bone with my own eyes. That's a lot of blood and tissue and scarring. Instead, I do a CT spin navigation. I put on this really fancy helmet, which obviously I don't have here. They're about $200,000 for the whole system. I can kind of see through your skin. I can see through your skin. I can see the bones. And then using this technology, I can look here, place that screw minimally invasively through the slit, and then break it off underneath. How does that fix spinal stenosis? It's almost like an accordion, where if I squeeze everything together, is my kid waking up? If I squeeze everything together, it pushes out. And if I pull it apart, it pulls all that spinal stenosis back in and stabilizes that area. So that's why spinal stenosis can get fixed with a fusion. But you don't always have to do a fusion. I think my kid's about to wake up. Am I going to have to roll here? Let's see. Okay, we got minutes to go. So that's one way. In terms of when will your pain go away after a fusion, that's like a really loaded question. How about this? If you have leg pain or nerve pain because of the pinched nerve, in a way you should wake up with the majority of that pain gone. Like if your nerve is pinched and I'm taking the pressure off, that pain should be gone that day or over the next couple of days. Now, it's not uncommon at all to have something called reinnervation pain. And the way I describe it, it's almost like you're growing blood vessels around this nerve that's previously been crushed for so long, and that causes it to depolarize and shoot down pain receptors. That's reinnervation pain. So yes, your pain's gone, big major quotes that day, but you might have it here and there, or even pretty bad for a couple days, couple weeks after. That's not uncommon at all. But that's the goal. Surgical pain. I've never had that surgery myself, and I'm sure I'm going to be humbled the day I do have to go through something like that. But it's something where you will have that surgical pain for at least 4 to 5 weeks after. It gets better every day, some good days, some bad days. But at the end of the day, there's a knife going through the skin, going through the tissue, and that hurts. I have a lot of patients who start to really feel good after a 2-level fusion where I go through the belly and go through the back, starting 5 or 6 weeks later. That's when I discontinue the brace, and this is for the spinal stenosis. I start formal physical therapy. They can start lifting up to 30 pounds. They can kind of go from there. Look, does that fix all your spine pain? Maybe, maybe not. I tell patients all the time, look, if I'm doing the majority of surgery I do are 1-2 level fusions. I'm fixing the areas that are the worst areas. There's many patients that still have terrible spine disease up here. Is that source of their pain? Is their sacroiliac joint a source of the pain? Is the hip joint a source of the pain? Are they a little larger? Are they carrying weight and it's pushing the spine? So is spine surgery going to fix all of your pain? Maybe, but maybe not. It's all about setting expectations. Spine surgery fixes spinal stenosis. It does great for shooting down pain. But if your spine looks like garbage, I kind of go back to that car analogy. If your car came in, if your car rolled down Central Expressway, caught on fire and burst into flames, and you bring it into a car shop and you say, fix me, you need to have some realistic expectations. But if your goal is just to get driving again, we can maybe do that. If your goal is to fix the leg pain and you've been putting it off for 10 years, that's something called chronic nerve damage. There's not a way to reverse nerve injury. There's not a way to reverse spinal cord injury. So I'm not saying go do surgery the second you start having symptoms, but it's also just setting expectations with the patient. And I think I do a good job of that. I think a lot of spine surgeons do a good job of that. But it's unfortunate too often patients say, hey, especially in comments, I had surgery, I still have pain, don't ever do surgery. I don't know if I like that argument necessarily. There's definitely many reasons not to do surgery, but too many patients are scared away from surgery or delay surgery too long, especially for spinal stenosis, when maybe the easy answer is just an outpatient ultrasonic laminectomy, and they do great. Great question from Junebug. I had grade 4 spondylolisthesis in the surgery when I was 14. Okay, I was taken out of grade 3. I'm just about a year post-op. My nerves still hurt. in some spots, but are numb in most. That's a really good post there. I think it's too narrow for everyone to be too interested in it. But June, that's great. Thank you for sharing that. You're right. It's something where if you are grade 4 or grade 5, usually you are adolescent. You're in your teens because it's kind of a different pathology. Usually adults don't get the arthritis and just slip to where they dislocate. It's kind of something you're born with, and it almost dislocates very young age. And then June, in your case, I don't know your case at all. Just in general, if someone's severely slipped, the surgeon might not want to reduce it all the way back. In fact, it might be bad to reduce it all the way back because it might create too much stress on that nerve. And that in itself might cause something like a foot drop. But if it's like a grade 1 going back, that doesn't normally do it. Grade 2 going back. But if it's like a grade 4 going all the way back, there is a good debate. And you just try to get it good. You don't need to have it be radiographically perfect. So I don't think you were criticizing your surgeon at all. But when you say I was grade 4 and got down to a grade 3, that's great. Sometimes you don't want to reduce it all the way. In fact, many cases, if they're grade 4 or grade 5, you do something called an in situ fusion. Big fancy word for you just fuse it in that spot. I was actually just talking to this 80-year-old lady this week in clinic. I don't want to operate on her at all. She doesn't want a surgery at all. And thankfully, she doesn't want the surgery at all because, if someone has to do it, it's got to be me. But, she's got spondyloptosis, essentially. I'd have to go through the belly, put a screw through those two bones, do something called an A-lift at 4-5. Again, she's 80. And then fusion L4 down to the pelvis. I got a DEXA. Her bone density is actually fantastic. It's not even osteopenic. Showed it to two of my senior partners, and they kind of agree there's no way to just get away with doing a laminectomy. You kind of have to do a fusion. Thankfully, she really just is too afraid of the surgery, which I'm happy she is. And she's going to try some more injections and hopefully get another opinion, just because I'm not looking to do multi-level fusions on 80-year-olds unless they absolutely need it. She might absolutely need it in a different case. Great question here from Linda. Can you recommend someone in Pittsburgh? I can. We interviewed a guy. We liked him a lot. And instead of living here in beautiful Dallas, he wants to live in Pittsburgh, which is where you live. So I'm sure that's a great city. I'm trying to think of his name. Just give me, Warros. What is his first name? Oh, you know what? Now that I got two cell phones now for the next 2 weeks, I can look up his name. Hold on really quick. Warros. I know his name. His name is probably Richard Warros, Wawrose. Good guy, liked him a lot, but he took a job in Pittsburgh, out of all places, which is great. Good place. Well, I think with that, I'm going to start to head out here, but I usually say I close this feed here, and I'll keep this feed up because this one records, and if I give recommendations, probably shouldn't do it too much on the recorded line. I'll do one more question from a person who just asked. Says, if your A-lift didn't fuse all the way, does the micro movements cause pain all around the lower back, or maybe cause the one above to go bad faster? So let me answer that and kind of set everyone up to speed on what I think the question means. Again, I don't know who that person is. This is just in general. Let's talk about that question. If someone gets something called an A-lift, where you go through the belly and put in a spacer here at L5S1, and you get a fusion just at L5S1 with a plate at L, or with or without a plate at L5S1, but no pedicle screws in the back. None of these screws in the back. That's fine. I actually do that surgery frequently. Of the times I go through the belly, I would say 2 out of 10 times I don't put screws in the back, meaning 8 out of 10 times I use screws in the back. When do you need screws in the back? When you have a fracture or the instability, that's usually more indicated to have the screws in the back. So you are bad enough to need a fusion, but not to need the screws in the back would be the case. Okay, great. So let's have a good fusion rate. But do they need the screws in the back or not? The screws in the back probably increase your chance of fusing it a couple percentage points. It might be overkill. It might not. So adding the screws in the back, give it more stability. Does that mean we should add screws in the back to every single time we go through the belly? I don't know about that. That might be overkill. So say you didn't get the screws in the back. Say you get something called a SPECT, SPECT-CT. That shows increased bones being mad, bones being pissed off, for lack of better words, increased uptake of the spec CT stuff. Oh my god, there's the loudest thunder of my life, and that can show micro motion at that area and pain. Associate that micro motion. So that definitely could be an indication to then minimally invasively, 2 slit incisions, place these minimally invasive pedicle screws down to that area and fix that non-union there at L5S1. So does that micro motion cause pain? Maybe, maybe not. Say you had a non-union, that doesn't necessarily mean you have pain. Well, if you're seeing a doctor, you're having back pain, that could be an issue. And if you then get a spec CT and it lights up bright and you're having back pain, it sounds like an issue. Okay, I got to go. Okay, I got to go. My kiddo's calling my name and that'll be it. Okay, go ahead and subscribe. I got to go.